Okay, good afternoon, and Dr. Yaffe and I are here to go over the numbers for today. The aspect we're going to look at today is some of the variations you're going to see in some of the numbers, as people are going to be asking some questions. What does it mean? What doesn't it mean in that regard? So I'll talk about that after we get today's numbers from Dr. Yaffe on that. So over to you, Dr. Yaffe.
Okay, thank you. So good afternoon. As of 4 p.m. yesterday, in the Integrated Public Health Information System, IFIS, we have a total of 15,381 confirmed cases of COVID-19 in Ontario. This is an increase of 525 cases, or 3.5% from the previous report. You may recall the previous 3 days we were going down. We've just gone up, but it's a bit of, we do get blips in the data. So after several days, we have now seen the rise again. And this is why we continue to ask all Ontarians to remain vigilant in following public health advice, practicing physical distancing and staying home as much as possible. We do see Ontarians recovering from COVID-19, with 58% or 8,964 of our cases considered resolved. Unfortunately, we have seen the number of people in hospital go up to 957, and the number of people in ICU similar to yesterday at 238. And tragically, we do continue to see deaths related to COVID-19. To date, 951 deaths have been reported, which represents an increase of 59 from the previous report. With respect to what is occurring in our long-term care homes, the Ministry of Long-Term Care is reporting now 154 active outbreaks in long-term care homes, 705 deaths have been reported among residents, and 1 death among the staff. With respect to lab testing, we have completed 253,040 lab tests for COVID-19 in Ontario. We currently have 6,282 under investigation, and in the last 24 hours, we've completed 10,852 tests for COVID-19. I'll turn it right back to Dr. Williams.
Well, thank you. And part of what Dr. Yaffe was alluding to is that I know people were saying, okay, we're on a good trend direction. We've come down 3 days, and now we jump up about 100 cases up to 525. Why this is important to note, and to, on an encouraging side, I wouldn't jump to any conclusions on that basis there. We've been saying all along, data collection systems change and vary. And if you change some of your testing methodology, you will see some alterations in that, and you have to take that into account when you're doing your data cleansing, or as cleaning up as a way in that. So one aspect we haven't taken into account yet is that we did ask as a special engagement of our public health units combined with Ontario Health Regional, along with the assistance of other sectors, to undertake with the long-term care homes a intense survey of well over 85 long-term care facilities throughout Ontario over the end of last week, over the weekend, and early into this week, to be completed by Wednesday. This was sampling all staff and residents in those 85 plus locations, and that would be important to complete and get that data in. Some of that data is flowing in, and no doubt will impact some of our numbers. So we're hoping again to extract that out, because one, that does demonstrate a separate undertaking to identify a number of aspects in there, including how many in those homes, how many residents and staff are positive, how many are negative, and how many of those were presumed to be asymptomatic that tend up to be positive in that regard. So we hope to have that completed by the end of this week, and to deal with that. But that no doubt will have an impact both on the volume of testing being done, but also on the some of the counts and numbers in there. At the same time, we see some changes in our long-term care numbers, and somewhere you actually see some reduction in cases in that. We have undertaken to have, with our data analytics group, a review of all our data systems, including rectification of some problems and challenges. And that data, I call it data cleansing process, is undertaken where you're asking each one of those administrative institutions to look at your data reports and to reconcile any differences and challenges. And there may have been some things over-reported in the wrong columns and aspects there that have to be reconciled in that. So these little variations, and these may be little but sometimes large in these day-to-day, you have to take that into consideration with the current data entry systems, the data management and cleaning systems, as well as new endeavors and new surveys undertaken. So while it may seem disappointing to people that we went up to 525, I would take that in the context of what we're undertaking to do in regards to the long-term care homes, and we hope as the week goes on, we'll be able to clarify that further to understand what is the situation, because we've again asked to have those two separated out, the long-term care data from the community side, so we can make sure if that's a real increase or not, and is it significant, and how do we handle that. At the same time, even with that data, with the number of tests done, our positivity rate, where we were down, then it went up, and now it's back down again. So you can see on your sampling, you'll get that variation in there. And as Dr. Yaffe said, some of these blips, these one-day things are to be looked at, but it's the overall trend that's important to see in that time and period there. So those are the aspects with today. And with that, I'm going to hand over for questions because we did start a bit late.
Okay, we'll open the phone lines.
Comes from Cynthia Mulligan with City News. Please go ahead. Cynthia, your line
Hi
is
there.
open.
Yes, hi there. I'm so sorry. I had to take my my phone off speaker. Doctors, could you tell me, earlier the health minister referenced a UHN study that is projecting that there would be 35 heart patient deaths because they did not get surgery due to pandemic planning. Are there any other modeling numbers? For example, for cancer patients, we know roughly 1,700 cancer surgeries have been postponed if we look year over year.
So, to be honest, I haven't read the study, and I understand it's not a study, it's actually a modeling project looking at some aspects in there. And as you've seen, we've been talking about modeling and how it works, and the various components are in there. Modeling is a complex endeavor to mix in a lot of different components in there. How well it is to project these things, I can't really comment on until you see it. There's a number of assumptions that are based there. There's baseline data. And of course, it would be based on how this compares to a pandemic type process, which this is our first pandemic. So, and with this amount of elective surgery being held at this time, so therefore, I would always say it may be interesting, it may be informative. I'd have to look at it, and some of our experts or modeling people may look at it and saying, does it make sense? Doesn't it make sense? Are the assumptions correct? And so it is always, any modeling is useful to be informative, to ask questions. It's not definitive in that because it's not based on real-time data. And as far as how it compares, and you ask about other studies modeling other disease entities, I don't think the study did that. And whether someone else is going to do that, it could happen in the future, but we'll have to wait to see how that is, and then to compare those and peer review those and see how it matches with some other ones. So, as I said, I find modeling projects are useful for consideration of potential issues, but it has to be really mapped into real-time data to see if it actually has, it was an accurate projection or not in that regard.
Okay, for my follow-up, Dr. Williams, do you believe that there will be patients who die because their surgeries have been postponed? And is it necessary to keep the hospitals at the roughly 64% capacity? Could we not start resuming surgeries now?
So throughout this time, there have been patients going through and having surgery, some in that line there, including cardiac surgery, so that in the mind of the physician, if it's elective, but some electives become more essential and some essentials become urgent, Nothing stops the physician from moving that on to an issue and saying this needs to be dealt with now. It might have been elective back 2 or 3 weeks ago, but in my mind, this is urgent and it needs to be dealt with. That's fully within the purview of the physician, the surgeon, the specialist to undertake to do that and to use the resources and facilities accordingly. So nothing prevents that from happening. So my understanding would be that anyone who is in a situation where their condition has deteriorated or was concerned, that the physician would ramp that up to being an urgent issue and to deal with it accordingly. And I understand from talking to some of physicians I know in the field that has and is continuing to be dealt with, because as you notice in some of our data, a number of the ICU beds and the ventilators are in use, and they're not in use with COVID patients. This is part of the reality that the hospitals have to deal with and not circumvent any patients who need urgent care. And so that kind of issue is not one that we would want to see happening, and would assume that the physicians would be doing that kind of process accordingly.
Next question.
Question comes from Mike Crawley with CBC News. Please go ahead.
Hi, doctors. Dr. Williams, follow-up to my question about community transmission yesterday. Do you have any sense of the breakdown of where people are contracting COVID-19 out in the community, in the sense of, is it happening at workplaces? Is it happening out in other public settings? Is it happening when they're going out for walks? Any sense at all?
Right. And you must have been at one of my meetings because I was raising the same issue again, because looking at the data now, where we are in the process, to me, some of the data points that have been accumulating over 3 months start to become less meaningful. What we really want to look at is incidence and prevalence, and that's what you're asking for, of some new cases. Isn't it better to collect that data, to do some more detailed analysis on that, and to segment it, if in a way, or break it down, looking at various components? Who's getting affected? What's the demographics of this group still getting infected? What's the locations? What's the case contact information? So that's the shift we're trying to endeavor to get to. So on that point, I agreed with you yesterday, and I agree with you again today. That's what I would like to know.
Follow up?
So could you explain, though, why that particular aspect of the data hasn't been tracked until now by the local public health units?
So the local public health units are entering that into their IFAS data. Some of the new ones that have just happened, like the 525 today, of course, some of it will be in there. But when they undertake to do that kind of analysis, as compared to straight just administrative, did the test positive or negative, you have to take that in. You have to carry out your thorough investigation. That means interview the case, interview those around the case, and ascertain on an investigative process where the potential sources are and are there any trends and directions. As they put all that in, some do it throughout the process, some wait and get all of it done on paper and then enter it in that regards. There's variations in different health units. So we're trying to get them to ramp up that kind of data entry so we could ascertain on the basis, not what happened 2 weeks ago, but what happened to the cases entered 3 or 4 days ago. Because we've talked about that before, about when the tests get done and that delay in the period and follow-up. So what we're looking at those data today were events that happened 4 or 5 or 6 days ago. So you can see why the timeliness is critical. So all these are important parts to ramp up the system and to give us, myself and I think the Ontarian public writ large, is a better current metric of how are we doing, what's going on, and what's not working.
Next question.
Haley Cooper with News Talk 1010. Please go ahead.
Hi, Dr. Williams. Hi, Dr. Yaffe. Just following up on Cynthia's questions, you mentioned, Dr. Williams, that if a patient, if their care becomes urgent, they will get the medical attention that they need. But oftentimes, by the time they become urgent, it's too late. So we're just wondering, when the pandemic plan was being drafted, did the province resign itself to knowing that some people would die in order to save space for future COVID-19 patients?
No, that was never an aspect on the table that they're going to allow that to happen. I'm not sure I agree with the comment that by the time that the physician or surgeon is made aware of the situation, it's too late to do something with. I would hope that the ongoing communication, we have the K codes, there's the virtual stuff, and informing the surgeon or physician or specialist of the situation would happen in a timely fashion, and continuing monitoring the patient during that time. And I am aware that a number of physicians are doing that and undertaking. And I think I would disagree, and the physicians probably would say if it's urgent, they will advocate and make sure the person gets in, including calling, having the person come in through ambulance into the emergency department and get seen. And that's what we would expect to happen. No, we did not plan that it was acceptable to have patients die unnecessarily during this time of delaying elective surgery in that. And certainly we see the emergency departments are still being utilized in that sense. The hospital beds are still being utilized, the ICU beds in that. So it is still being undertaken at this time. So it was not in the plan, and it would not be acceptable to put that in as a caveat to be allowed. No.
Follow-up?
Thank you. I don't have a follow-up.
Question?
From Rob Ferguson with the Toronto Star. Please go ahead.
Hi, doctors. Just trying to get a bit of handle on the change in the testing numbers. Yesterday, the report was about 12,550 cases, and today it was down to 10,852 tests that were done. That's about a decrease of almost 1,700, or just under 16%. Do you know what happened there? Are we having more shortages? Because there's still lots of people under investigation, so it can't be a shortage of test to process.
I think it may reflect reduced activity over the weekend, because the data is from about 2 days ago. But overall, the numbers are up.
Right, but what I don't understand is the if we're trying to get up to 16,000 a day, and there's still 5,000 or so people waiting results, why couldn't that excess capacity be used?
So, yeah, like yourself, you're following the math here. And as Dr. Yaffe said, over the weekend, there was a whole bunch of lab tests that were done, and some were done by community labs that are still being transported into the central to get done. So there was some time delay in moving them forward for testing, and they're being undertaken at this time. As far as the capacity side, it has to be on the basis of, one, people have to come forward and get tested. The assessment centers, even on their weekend, every weekend we see a dip in the number of people that go in for assessment. And even on this past weekend, I'd say nearly 90% of those who came in for assessment got tests done, but the number was lower than during the week. It usually, interestingly, starts going back up on Monday and rises to a high about Thursday and Friday, and then drops back down again over the weekend. So that's usually a difference of about 1,000 to 2,000 in there. And that's just a matter of the people coming forward to get tested. In the other one we're doing with the studies on the long-term care facilities, that was more working with our community health, our community labs, and moving these samples around on the weekend and dealing with the timeliness of the testing, as Dr. Yaffe alluded to. It was down on the weekend, so we've got some extra ones to do now to get back up to that capacity. So, not up to capacity, we get all the tests done that need to be done in that regard. So it's a matter of demand as well as utilizing the testing for our enhanced surveillance as we have undertaken with the long-term care IMS group. So as I noted at the outset with one of the questions or my opening comments, we have undertaken in the field to do well over 85 long-term care facilities throughout Ontario to all staff, all residents, and those samples are still coming in and in some large numbers to get processed yet. So we still have to see the impact of that as we go into these the results tomorrow and Wednesday. So I think we'll have to stay tuned and see how that affects our overall totals.
Next question.
Your next question comes from Allison Jones with Canadian Press. Please go ahead.
Hi, doctors. You've been able to break out the numbers of cases and deaths in long-term care homes. Do you have any similar data for retirement homes?
Yes, we do get, we're starting to get more and more data from the retirement homes in there. A little bit harder to say, to compare the difference. We do have the number of cases in there and deaths, and I did look at it this morning. I don't have them here in front of me. I can get them here in a second for you. And the challenge is that when you're talking about deaths and aspects related to retirement homes, most of the residents there, of course, because they're in an independent living setting, these are their apartments, if you may. So when someone gets ill in a retirement home, as compared to a long-term care home, they usually call an ambulance and the person is taken to a hospital and is admitted and seen there. If they unfortunately, while in the hospital, die, then is that death recorded as a hospital one or a long-term care or a retirement home. Sometimes the administration data will record that because they have to note that in their data collection, and how that's done in a timely way. We're still trying to work out so that retirement homes operationally and functionally in their data systems are different than long-term care homes. So we're trying to work with that and understand that to make sure if we're doing some recording, it's accurate in that regard. But as I said, I can give you those numbers in a moment here.
Actually, I found the numbers.
Oh, good. You got your book out.
I got my book.
Thank you. Go ahead.
So I think these are numbers as of maybe 2 days ago. This is for retirement homes. 56 in outbreak, 19 that have resolved, 588 residents positive, 114 deaths.
And the numbers for today, I actually had 56 new cases in there. It was down 17 to 588, and the staff was up by 2, and the deaths was up by 3, and the number resolved was 19.
Okay, Allison, you could have a follow-up.
I was just wondering if you're planning on publicly reporting this data the way that you do with the long-term care data now.
We've been looking at that to do that, and some have asked in the future, are we going to report on any congregant type things as well? So these are all being looked at and considered.
Next question.
Your next question comes from Miriam Adalia with Radio Canada. Please go ahead.
Hi, doctors. When it comes to long-term care homes, there's a significant gap between the number of resident deaths reported by the Ministry of Long-Term Care and Public Health Ontario. So, Dr. Yaffe, you said 705 deaths, so that responds to my question. But there's also a significant difference in the number of outbreaks between the two. Why is that, and who has the most recent data?
Well, as I've mentioned before, there are two separate databases, and they measure different things. They have different purposes. So the IFIS data, Integrated Public Health Information System, is the system that's used by public health units, and it's what we call an epidemiological database. So it includes a lot of detailed information about each case, and it's the demographics and risk factors and so on, and their disposition, as we say. And that goes into Public Health Ontario. And sometimes there's a lag in the data, and it gets cleaned or reviewed and updated. The Ministry of Long-Term Care data is an administrative database that's run by that ministry, and it's more literally counting numbers. And so we've chosen to report both on our website for transparency, but we consider the Ministry of Long-Term Care database to be more current, more up-to-date. So that's the one that we're using for quoting numbers.
Follow-up?
And I would just add that the IFIS data, if you're using the IFIS report, theirs is cumulative from January 15th to the 27th. The long-term care data is active, so there is and have been some resolved. So there is that is almost in the range of the resolved ones added in there. So I think you have to see one is cumulative, one is active.
Follow-up?
My other question is, do you think that you have a better picture of the crisis in the province with the number of tests being done now? Like, how is Ontario doing at the moment?
I would say you say crisis or crises, and because you said we have our community outbreak, we had our issue in the hospitals, worried about the load on the intensive care units, on our ventilators. That is one aspect that we've looked at, and the modelers have dealt with that. We now have the one in the long-term care home. We're trying to work assertively with the IMS table under Dr. Kevin Smith, and that group's looking at that, as well as our use of surveillance data to get ahead of that, to give a better picture to that IMS table, to understand which units are more at risk than others and what they have to do to move alongside to not only respond to, but proactively prevent and move them up to a more better able capacity to deal with any issues that may come down the road. So we're not just trying to deal with, but to prevent. Then we have our issue related to the retirement homes, and now we're moving to the ones with the congregate settings, with a wide variety in there, including prisons, as well as issues related to how homeless and shelters. So each one is different, each one is important, and we're trying to make sure we can move them off from being a crisis into a handled outbreak situation to deal with that as COVID-19 works its way through different sectors in different ways. So the data always does help. The data is specifically, if it's collected, as we're doing now with long-term care, to deal with each one individually, gives you a better picture of that situation. And then does that give you another idea of the composite for the whole province? And of course, we've talked many times about the difference between the community cases versus long-term care, then versus retirement, and then it's going to be versus congregants. So if anything, it's going to be a little bit more complicated, but we hope to be able to give clear messaging so that each person who's concerned about which sector would have an idea of what is going on in those respective areas, and then the composite for the whole province.
Okay, moving on to our last caller.
Your final question comes from Mo Fahim with Vista Radio. Please go ahead.
Thank you. Can you hear me well?
Yes,
we can
go
hear
ahead.
you.
Perfect. First of all, good afternoon. Thank you for taking questions. My question is, I'm looking at the long-term care data right now, and it's showing that I guess compared to a couple of days ago, we now have less, a lower number of active cases of positive residents, while the number of active cases of positive staff has gone up. My question is, are we looking at a mini surge of cases in in long-term care workers here?
So I sent my introductory comments, and I'll go back to that again. We've been asking to go through with if we're going to use our long-term care data, there's a need to make sure there's a data rectification process. So if sometimes organizations call in and give their data amounts, they're asked to go back and say, is this accurate or not? And sometimes they find inconsistencies where they double counted some things and shouldn't have done there. So part of this going down, which you'd say would be pretty unusual unless there was errors in data entry in that. The fact that the staff cases going up by 18 has been sort of a pattern we've been seeing for a time anyways. I just think that the other one with the minus is, to me, more of a problem of data rectification, because I would think, if anything, our cases and positive ones would still be on the increase, but there may have been some counting errors in that with the administrative data, and now we're using it as very much a metric. We want to make sure it's done very cleanly and very accurately, and there's systems to do to rectify that.
Follow up?
And I'm not sure if you mentioned it in your opening remarks, but how many of today's new cases were reported from long-term care homes?
Well, and therein lies a challenge, because they're rectifying data at the same time of reporting new ones. The actual delta or difference is harder to calculate. So I was trying to give the sense that the 525 were people saying, is that increase in community or is that increase in long-term care? The answer is right now I don't have that definitive one because of the extra large sampling that was undertaken in the long-term care facilities, and those samples are coming in a bit delayed over the weekend into this week now, and they may be impacted already. So we are hoping to get a better sense of that as the week goes on, and that data is rectified both in the IFA system and in the long-term care as the results go back to those various institutions.
I think another caller dropped in. We're going to move to the next question.
Your final question comes from Stephanie Smith with CP24. Please go ahead.
Hi, doctors. I noticed there was an opinion piece in the Toronto Star today, and it was quoting Dr. Michael Warner from Michael Garron Hospital. He's the medical director of critical care, and he says in the ICU, they're now using ventilators, being intubated as a last resort. Instead, they're now using high-flow nasal cannula, which is basically, they say, nasal prongs that were initially banned in the ICU. So he says they come full circle from banning a certain treatment to using it almost exclusively in a matter of 2 weeks. My question is, what does this mean about the race to manufacture ventilators in this province? I understand that the crush on hospitals wasn't quite what was expected, but are ventilators even as necessary as once thought to be?
Well, that's a good question, and it's been interesting to watch. And this is the thing when you're dealing with a new condition with COVID-19, as our clinical specialists, and such as Dr. Warner and others in intensive care, have been wrestling and dealing with these cases, and some have been ventilated for a long period of time, and they've done some in prone positions, using different medications and different types of paralytics, etc. Part of that is that they're doing active understanding and research as they go ahead. They're reading what others have done in other sectors, what they've done in Italy, what they're doing in New York, and I think that the field is basically learning, and there's some sense of where you have, I understand some of the early information is that maybe some people without mechanical ventilation still using the individual's self-induced through either different methods, such as even cannulas is the word, nasal cannulas and that. It helps in some better situations rather than ventilation. Very much being tried out and understood. So the modus operandum before was standard ventilation was definitively that with a ventilator 2 or 3, or at least 3 weeks ago. If it's evolving and moving in a direction away from that, I assume that's going to be evidence-based, and we're going to be asking for individuals such as Dr. Warner to continue to advise on the way forward of how to handle COVID-19 patients in their various comorbidities as well as age and demographics. So this evolution is interesting to watch, and we'll want to be informed by our clinical specialists as they forge ahead with the science and knowledge and working with their counterparts across Canada and internationally to give us a better understanding.
Follow-up, and this is the last question.
Thank you. Do you think that then in this case there is still that crushing need for ventilators then? Is this a new, just another step that's being learned in what has been called by officials a sneaky virus?
Well, I mean, if this is a direction they're going to say is the one that they're going to go in a strong way away from ventilators, I think ventilators are still going to be used for certain clients sometimes. If it's going to be not the preferred, another method, that would certainly change the demand in that, and that would be helpful in that sense if that's truly the recommendation of the specialists writ large. Across in Ontario and in Canada and internationally. So we continue to learn and to be advised, and we want the most up-to-date and best evidence-based information to make these decisions. So we applaud the specialists for trying to do whatever they can to make sure that our mortality rate stays down, and certainly that more people are discharged from ICU, and we only would like to see that improve in the future by whatever means they do.
Thanks, everyone.